All right, John. So you highlighted a number of different neuromodulation techniques that are incredibly impressive. When we're thinking about the CCFES and in post-stroke rehabilitation, what are some of the key patient factors to determine best outcomes that we need to consider?
Well, there are things that we learned during clinical trials, and of course, then there are things that I wish we could do outside the clinical trials. Okay, so things we learned in the clinical trials are the following. It seems like the individuals that benefit most are people who have some residual hand function, but also not too far away from the actual stroke event. So preferably within 6 months or less. So this is consistent with what we do know, that activity-dependent neuroplasticity is significantly enhanced early after stroke as versus waiting too long. So that is what we know from the trials itself. Now, we didn't do the trials in what we call acute stroke patients. That people who are in the hospital 4 or 5 days or 6 days, or even a couple of weeks. My hope is that this could be applied that early to kind of jumpstart neurological recovery. But by necessity, our clinical trials enroll people who are further out.
Okay, that'd be incredible if we can get to that point. Hopefully we will. And then thinking about, and you highlighted this so well, going from clinical trials to practice and some of those barriers that we face, what is one of the most important barriers that you recognize nowadays that as rehab professionals we need to be thinking more about, and how do we tackle that?
Wow, as I indicated in the presentation, there are probably 3 factors. One is patients need to be able to select it. Number 2, the clinicians must believe in it to offer it. And number 3, somebody needs to be able to pay for it. Now, I also mentioned a 4th factor, and that is it depends also on who is funding the company that is commercializing. And sometimes the funding mechanism may not match the actual dynamics of how these things roll out. But putting that aside, those 3 factors are the most important, which means that when we do our clinical trials, we have to be very thoughtful about our outcome measures. Outcome measures must be clinically relevant, number 1. And number 2, we also need to demonstrate that the effect is enduring, right? And then how do we then interact with the clinical community? And my personal opinion is that when we do our clinical trials, we actually have to get the physicians who are actually going to be prescribing these things to participate in the clinical trial so they can say, hey, I own this. So those are the fundamental issues.
Yeah, some skin in the game, right? And so lastly, thinking future forward, where do you see neuromodulation moving towards in the next 5 to 10 years? And is there a role that you find will be clinically meaningful with AI?
2 questions, but maybe combined. As much as I enjoyed working with these approaches, I also believe we've actually have reached some sort of a glass ceiling as to how much we could encourage the nervous system to do what we want it to do. I wonder if regenerative medicine, stem cells, more biologic solutions are the way to go. Where can AI come along? I wonder if we can use AI to look at varying combination permutations of all these elements biologically that we could use. There's so much out there. To do a search and evaluate each one can take forever. Very similar to drug discovery in cancer. So for all intents and purposes, almost infinite combinations. AI is helping to identify those molecules that could potentially target where we want to go to. So I think maybe there's some parallels with that.
Yeah, definitely. Well, thank you so much, John.
You're welcome.
Incredibly impressive.
Thank you.